As you know, the topic of this ISUP presentation is the definition of, is the definition of cribriform pattern prostate cancer. The past few years, cribriform pattern prostate cancer has received a lot of attention because of its distinct prognostic implications. It is therefore important to diagnose cribriform pattern prostate cancer correctly, and that's why the ISUP installed a working group to draft a definition of cribriform pattern prostate cancer and to generate an educational slide set. And this lecture presents to you the results of this working group. By the way, the images on this title slide depict my wife's sieve, a cross-section of Japanese lotus root, which I'm told by very reliable resources that it is a Japanese delicacy. And on the right side, you find the sieve elements in the bark of a tree, and they all share this kind of cribriform pattern, as you can see. So cribriform pattern is not necessarily a feature of malignancy. It is important to realize that cribriform pattern may also be seen in benign prostate glands, such as cribriform hyperplasia, basal cell hyperplasia of the transition zone, in the central zone glands even, and maybe in high-grade PIN. I will discuss that later. So don't confuse these benign lesions with cribriform pattern carcinoma. In malignancy, cribriform pattern is most commonly seen in invasive conventional acinar carcinoma, but also in intraductal carcinoma, ductal adenocarcinoma, and also in a rare form of prostate cancer that is called adenoid cystic carcinoma. Here, examples of cribriform hyperplasia and basal cell hyperplasia. And both are well-circumscribed small-sized glandular structures characterized by bland nuclei. They lack prominent nucleoli or atypia. They are rare in prostate biopsies and they occur in the transition zone, and invasive carcinoma is generally not in the vicinity of these lesions. Below you see an example of florid basal cell hyperplasia, and to be honest, I picked this picture from Dr. Strictly's excellent review on benign mimickers of prostatic adenocarcinomas. Basal cell hyperplasia has the typical basophilic appearance due to the high nucleoside to plasma ratio and can be seen particularly in the context of a BPH nodule. Due to tangential sectioning, a normal benign prostate gland may also give the impression or the appearance of a cribriform architecture, and deeper sections and absence of nuclear atypia might reveal its true benign nature. Sometimes the typically more complex central zone glands may also give the impression of a cribriform architecture, as being shown in this image. Although nuclei may appear somewhat atypical and vesicular and somewhat enlarged, a prominent nucleolus is generally not present. If one searches the internet for cribriform high-grade PIN, one generally finds pictures of intraductal carcinoma, like you see on the image here on the left side, or a tangentially cut tufted type of PIN. The literature also mentions cribriform PIN as one of the 4 architectural patterns of high-grade PIN, being tufted, flat, micropapillary, and cribriform. In the past, intraductal carcinoma was considered by some as a variant of high-grade PIN, but now it is well recognized that intraductal carcinoma and high-grade PIN are different biological entities. High-grade PIN does not have much clinical consequences, whereas intraductal carcinoma is considered a real adverse feature. Nowadays, I do not diagnose cribriform high-grade PIN anymore on a biopsy, and according to the paper referenced below by Shah et al., it should be reported as atypical intraductal proliferation, provided that basal cells can be seen and can be identified. Intraductal carcinoma commonly has a cribriform architecture, but is distinguished from cribriform pattern invasive carcinoma by the absence of basal cells. Cribriform architecture can also be seen in a very rare anoid cystic carcinoma of the prostate on the right slide, on the right image on this slide, and they are composed of cells with a basaloid morphology. Further, ductal adenocarcinomas may also display cribriform morphology, generally in the context of areas with the typical papillary features of ductal adenocarcinoma, but sometimes larger areas of cribriform pattern can be seen. Here the tumor cells have a more cylindric or columnar appearance. Over time, the significance of cribriform pattern prostate cancer has changed. In the 1970s, the well-defined and more regular cribriform patterns were considered Gleason grade 3, and the irregular rect form of Gleason were considered grade 4. At the 2005 ISUP meeting in San Antonio, essentially all cribriform pattern prostate cancers were assigned as Gleason grade 4. Many subsequent studies have shown that among the Gleason grade 4 subpatterns, like fused ill-formed glomeruloid, and also as discussed by Dr. van Leenders in the previous ISUP Presents lecture, the cribriform pattern conveys a more unfavorable prognosis in terms of increased risk of biochemical recurrence, metastatic disease, and death of disease. And this seems to be an independent, clinically independent feature. How about reproducibility among pathologists to identify cribriform pattern? This scheme, based on an inter-observer study by Kveldam et al., shows the various morphologies like Gleason grade 3 and the various Gleason grade 4 patterns, such as ill-formed, fused, glomeruloid, and cribriform pattern. From this study, it appeared that cribriform pattern was the best recognized pattern among all the grade 4 patterns, but most discrepancies were between grade 3 and ill-formed or fused glands on the one hand, as can be seen in the upper part of the scheme, while fused glands and cribriform may also cause confusion. A pattern consisting of anastomosing strands, termed complex fused glands, was also shown to cause disagreement to call cribriform pattern. And we will see in the later part of my lecture some examples of this. Occasionally, the glomeruloid pattern can also cause disagreement in pattern attribution. Last year, September, the ISUP convened a consensus conference on grading of prostate cancer in Nice, France. And one of the recommendations was to report on a routine basis the presence or absence of intraductal and cribriform pattern carcinoma. So in your pathology reports, it is now a mandatory element to report on the presence or absence of cribriform pattern carcinoma. This recommendation was based on ample evidence of the distinct prognostic impact of cribriform and intraductal carcinoma, as highlighted in the previous ISUP lecture. It was thought that there is an urgent need to have a practical definition of cribriform pattern to standardize its reporting by pathologists all over the world. We need a practical definition. There are already a few definitions in the literature based on individual pathologist opinion, but there is actually a need for a more authoritative consensus definition by a panel of uropathologists with a strong reputation in the field. Therefore, the ISUP established a working group of 12 panelists. Members of the working group are listed on this slide, and the conveners were Lars Eggevat from the Karolinska Institute and myself. The working group members are all well-known uropathologists from different parts of the world, as you can see, and 7 of them published outcome studies on the topic. The working group employed a Delphi technique, that is repeated surveys on the same images and same questions to obtain consensus opinion. The 2 conveners, that means Lars Eggevat and myself, were not allowed to vote. The objective given to the working group was to improve the pathologist agreement on the reporting of cribriform architecture in prostate specimens. After 2 rounds of anonymized surveys consisting of questions and images with feedback of the results of the previous round, a panel discussion was organized and subsequently a definition was drafted, followed by a final 3rd survey round. Prior to the surveys, a definition of consensus was formulated. Here again, in brief, the study design. The panelists were asked to indicate their level of agreement for each of 32 images. And the question all the time asked was, this image, does this represent cribriform pattern prostate cancer? And the answer could be strongly agree, agree, not sure, disagree, or strongly disagree. And anonymized results of the earlier rounds were provided at the 2nd round on the same set of images. Consensus was defined as at least 70% agreement or disagreement a priori, and no more than 10% strong disagreement or strong agreement with the statement. The set of 32 images were selected by the conveners from a larger set of images and roughly divided in 8 categories, including the category of definite cribriform as a kind of positive control to make sure that all the experts were real experts, essentially. I will now show you examples of each of the 8 categories and the survey results. This slide shows 2 images of the category definite cribriform, and you can see the category written on the bottom of the slide. In the table below each image, you see the number of the image number on the far left of the table. And in the first row represents the results of the first round, and the second row the results of the 2nd round, and the 3rd row the last round. For image 23, the right image, for instance, there was 1 disagreement in the first round, but in all other rounds there was no disagreement, and everyone agreed that this was there was consensus that this image or those both images actually represented cribriform pattern. Here, 2 cases of the category small size, as you can see at the bottom of the slide. A small glandular structure with 3 lumina can be seen on the left image. And most panelists disagreed with a diagnosis of cribriform pattern. There was strong disagreement or disagreement in almost all cases by almost all panelists. Only 1 panelist in the 3rd screening round agreed with the diagnosis of cribriform, but all of them were disagreeing, and there was consensus on disagreement. And on the right side, for the small lesion on the right side, consensus was achieved in agreement with cribriform pattern at the 1st and last round. With regard to the left image, the pathologists disagreed because they considered it more like a fusion of a few glands. The lesion was too small. The next 2 cases show a category solid or Gleason pattern 5 images, and they appeared very controversial. There was no consensus achieved on the left image, as you can see. This image contains a largely solid field of vacuolated cells, but a few lumina can be seen in the right upper corner. No consensus was reached in any round. The image on the right represents what we would call a pseudo-rosetting pattern. During a vote at the ISUP 2014 meeting in Chicago, this pattern was included as a Gleason pattern 5. But in many cases, a transition between pseudo-rosetting without open lumina and pseudo-rosetting with presence of small lumina can be seen. So this may apparently result in inter-observer variation. But in this case, consensus for cribriform pattern was achieved in all 3 rounds. Although in the 3rd round, after the panel discussion, the consensus diminished with 2 disagreements. Oh my God, we got a fire alarm here. But I think it's a test. For this borderline situation, the clinical impact is probably limited given the poor prognosis of both the cribriform and solid lesion grade 5 pattern.
May I have your attention, please?
I think I continue.
A fire alarm test. In the event that a true fire alarm should occur, you will be notified by
Excuse me.
Thank you for your cooperation.
In this slide, you see two nice examples of a mucinous fibroplasia or collagenous micronodule category. Interestingly, for both images, no consensus was reached during the first two rounds. Only at the third round, there was consensus disagreement after the definition of cribriform pattern was drafted. These images provoked a lot of discussion at the virtual panel meeting, and at the third round only there was consensus against cribriform pattern. Particularly some panelists questioned whether a mucinous carcinoma could ever be cribriform pattern. Would that be possible? Most considered mucinous carcinoma, even with complex glandular architecture, as low risk for poor outcome. So they were generally considered as favorable outcome. In this picture, taken from Dr. Samaratunga's paper in histopathology, with 6 images of mucinous carcinoma, an example of cribriform pattern could be found on the left upper panel. Nevertheless, this kind of lesions with kind of cribriform sheets of epithelial cells floating in mucin remains a topic for further investigation. On the left side of the category intervening stroma complex fused, where anastomosing strands of tumor cells may give the impression of cribriform pattern. At the third round, consensus against cribriform pattern was reached, as you can see. Although there was one strong agreement with the statement. There was one person in the third round who strongly agreed with the statement, this is cribriform pattern. The image on the right side represents a ductal adenocarcinoma, which also may display, as mentioned earlier, a cribriform pattern. In this image, however, a consensus against cribriform pattern was obtained both in the first and the second and the third round. Another category with a lot of controversy is the borderline glomeruloid pattern. Some believe that glomeruloid pattern can evolve into cribriform over time, although more recent literature argues against this notion. For the image on the left, where the glandular space is entirely filled with cribriform pattern, consensus agreement with cribriform was obtained in all 3 rounds, where the cribriform but for the image, on the image on the right, where the cribriform mass does not touch a large part of glandular contour, the initial consensus agreement of the first 2 rounds was lost. And at the end, there was no consensus whether to call this cribriform or not. The reason being that a large amount of the rim is not touched by the cribriform sheet, and that's why there was no consensus on this diagnosis. During the survey, we also asked a few questions related to the use of a size criterion for the definition of cribriform pattern prostate cancer. No one of these questions reached consensus during the 2 subsequent survey rounds. Apparently, a size criterion cannot be part of the definition. We also asked the panel whether they would report cribriform pattern if exclusively present in a perineural location, particularly in the biopsies, because sometimes that may occur that you see only the cribriform pattern along a nerve and nowhere else. But again, no consensus was obtained among the panelists. Some would consider cribriform pattern along a nerve as cribriform part of the prostate cancer, and others would argue that this is maybe an example of a differentiation into cribriform pattern due to the location around the nerve, and they would not call cribriform pattern just when it is only located around a nerve. The only question reaching consensus agreement was whether cribriform pattern exclusively in an extra prosthetic location would be reported as cribriform pattern, and 12 of 12 panelists would agree with this statement. They said yes. After the 2 survey rounds and a Zoom conference, virtual conference with our panelists, we discussed the results, and then next a consensus definition was drafted. The definition of cribriform pattern drafted by the panelists was as follows. As you can see in the upper panel, a confluent sheet of contiguous malignant epithelial cells with multiple glandular lumina, easily visible at low power, and then specified as objective magnification 10 times. There should be no intervening stroma or mucin separating individual or fused glandular structures. And we thought that this would be a very practical definition to be used. And the arrow labeled A depicts actually the difference between solid pattern and cribriform pattern, in that in the solid pattern there are no easily visible lumina to be seen. Arrow B depicts the situation where there can be intervening stroma. So the middle panel image on the right side does resemble cribriform pattern, but there is a very little bit of intervening stroma between the glands, and that makes that you cannot call this cribriform pattern. And arrow C depicts the situation with regard to mucinous carcinoma, where complex glandular structures are floating in mucin. So in the first round and the second round, overall consensus was obtained for 16 images, and in the third survey round of the 32 images, there was an overall consensus of for 21 images. This means that there remains a subset of images where the panelists would not be able to get to obtain consensus, and these remain kind of borderline cases, and we have to accept that this situation may occur, may happen. So now I'm going over to the educational side set of 32 images, but don't get a shock. I'm not going to show you all the 32 images. For that, you have to go to the ISUP website where there is a link provided to them, and you can do it for yourself. But we will do a couple of them with some comments from my side. So I give you a couple of seconds to look at this image. This is the image from the category definite cribriform, and you have a little bit time to think whether you would diagnose this lesion as cribriform pattern prostate cancer. And of course, I hope that, so this is the duplicate image, and I hope that you all would say, yes, I strongly agree, or we agree that this is cribriform pattern, because you see clearly larger, circumscribed, rounded sheets of epithelial cells with punched out lumina. Majority of cells are not in contact with stroma, so this fulfills entirely the definition of cribriform pattern prostate cancer. And as you can see, all 12 panelists in its third round, because I show you only the data from the third survey round of the panelists, all of them agreed with this. The second one is from the borderline small size category. And the question to the audience, to you all, you have now a few seconds to reflect on this. Would you call this lesion as cribriform pattern prostate cancer? And I give you a little bit more information. The diameter is 250 micrometer of this gland. However, this was not part, the size criterion was not part of the definition, so it doesn't help you really much. What was the panelist opinion? The panelist opinion was, yes, this is cribriform pattern. They said this is again a small-sized, rounded, circumscribed sheet of epithelial cells with easily visible lumina, no intervening stroma. However, if there would be basal cells around, that was the comment, it could be diagnosed as intraductal carcinoma, although I don't think it is distended sufficiently. And in that case, you would call it atypical intraductal proliferation. The next one, What is your diagnosis? Do you diagnose this lesion as cribriform pattern prostate cancer? You have a few seconds to think about it. There was no consensus, maybe a bit surprising. There was no consensus among the panelists. The six panelists would agree with cribriform pattern, one was not sure, and 5 disagreed with the diagnosis. The description is that this represents a larger sheet of epithelial cells with a few scattered lumina, no intervening stroma. Although lumina are visible, but they're not that easily visible. But again, the word easy is of course a little bit subjective. There was no consensus obtained. Personally, I would have diagnosed this as a pattern 5. I think the number of lumina is insufficient and this is not a clear-cut situation. On the other hand, we could also say that the distinction between solid and cribriform in this situation might not matter too much. This is a bit controversial, maybe what I'm saying, but the impact of both, the prognostic impact of both is pretty unfavorable for the patient. Here another example, an example of intervening stroma complex fused as a kind of borderline. Do you diagnose this lesion as cribriform pattern prostate cancer? Most cribriform patterns have a nice regular surrounded regular contour, but here it is a bit irregular, so it might be a little bit more difficult. You have a few seconds to think. Okay, when you made up your mind, let's see what we said, what the panelists said. As you can see, 10 out of 12 panelists agreed with the diagnosis of cribriform. So this means there was sufficient agreement to get consensus agreement. However, 2 panelists would not agree. The description is that this represents multiple sheets of epithelial cells with multiple punched out lumina. They're easily visible, no intervening stroma within the sheets. So you have separate sheets. There is a bit stroma between the sheets, but within the sheets, there is no intervening stroma. And the majority of cells are not in contact with stroma or capillaries, which is a kind of ancillary argument. What about this one? This is a bit a more complicated situation. This image is not from the educational slide set. This is a picture I just took recently. Here we see sheets of epithelial cells, but we see clearly intervening stroma and capillaries. But there are areas, if you look very careful, where a larger area within this kind of complex glandular structure has a cribriform pattern. And I think in this situation, you might consider this as, you still would call this as cribriform, but I'm sure that there will be inter-observer agreement among panelists. So this is an example where you have a kind of borderline situation between complex fused glands and cribriform pattern. I would consider this, personally, I would consider this as cribriform pattern. Here another example, a more clear-cut example of complex fused, where you have a bit cribriform appearance, but some capillaries, intervening capillaries and stroma are present as well. In fact, we do not really know what is the prognostic impact of these complex fused glands with these capillaries in between. And it might be that they have an equally poor prognostic impact as a cribriform pattern. We just don't know. So, associated with the definition of cribriform drafted by our panel, there were a few explanatory notes. And the criterion, there should be no intervening stroma separating individual or fused glandular structures, should help to distinguish complex fused glands from cribriform carcinoma. And the latter are characterized by the presence of subtle intercellular stromal cores. But borderline situations may exist, as I have shown to you now, and the prognostic significance is unclear. Here, an example from our slide set again. You get a few seconds to think whether you would call this cribriform pattern prostate cancer. This is from the category mucinous fibroplasia. Okay, you may have made up your mind. Don't think too long. What did the panelists say? The panelists strongly disagreed with this one. 12 out of 12 even, they disagreed. They did not call this cribriform pattern. The description here is multiple contiguous glandular acini with mucinous content. There is intervening stroma and capillaries, although delicate, and in spite of the cribriform appearance, there was consensus against cribriform pattern. Here another example, this is not from the educational slide set, where there is a much more clear sheet of epithelial cells, of malignant epithelial cells, contiguous epithelial cells with mucin, and this I would call cribriform pattern. This would be consistent with cribriform pattern. Again, there was an explanatory note for mucinous carcinoma fibroplasia, informing that rarely mucinous carcinoma may show a true cribriform pattern, but in most cases they represent fused glands. That is the explanatory note belonging to the definition. Glomeruloid. Here another example from the educational slide set. Do you diagnose this lesion as cribriform pattern prostate cancer? I have a pretty strong opinion on this, but not all panelists. And here we see what happens. There was no consensus. The panelists did not have consensus on this. 5 were in agreement, 2 were in strong disagreement, and 5 disagreed to call this cribriform pattern. Personally, I would not call this cribriform pattern, and I'm allowed to say that because I'm the presenter. I can say that now here. And the description is small glandular structures largely filled up by cribriform sheet of epithelial cells attached to less than 50% of the site. No consensus was obtained apparently. And another one, here's another one for glomeruli. Do you diagnose this lesion as cribriform pattern prostate cancer? You can make up your mind, please. And yes, there was agreement. 10 out of 12 panelists agreed that this was sufficient for cribriform pattern. The glandular structure, largely more than 50%, filled up by epithelial cells attached to more than 50% of the site. And most cells are not in touch with the stroma. That was the argument. So the explanatory note belonging to glomeruloid is written here. In general, the distinction between cribriform glands and tumors with glomeruloid pattern is straightforward, particularly when they're small sized. According to the ISUP 2014 definition, glomeruloid glands are dilated cancer glands of variable size with cribriform cancer protruding into the lumen, but not attached to the opposite side of the gland wall, superficially resembling a glomerulus. However, when glomeruloid structures within such glandular spaces increase in size, the morphology may border between glomeruloid and true cribriform patterns. And again, we do not know when these larger kind of cribriform areas in a kind of glomeruloid architecture arise, what their prognostic impact is. There are a number of publications showing that glomeruloid pattern cancer does pretty well, is pretty good, has a pretty good prognostic impact, but these larger glomeruloid structures are less frequent, and that's why more difficult to investigate. As in summary, this is the final slide of my presentation. A practical definition of the cribriform pattern of prostate carcinoma is presented here, including explanatory notes for its distinction of other growth patterns. This ISUP consensus definition should allow reproducible recognition and reporting among pathologists globally. The educational slide set may help standardize reporting of cribriform pattern prostate cancer, but we are aware that a number of borderline situations may occur where we do not have any idea. And areas of further studies are identified and include large complex glomeruloid and mucinous carcinoma, as well as complex fused glands with cribriform experience. And now I think the lecture is is open for questions. And I will stop the sharing here. I can stop the sharing, or I mute.
Just move on to the next slide, Theo. We haven't got any questions at the moment. There's a Q&A thing at the bottom of your Zoom if you want to ask some questions. So one of the questions that springs to mind is that I never quite know whether to grade prostate cancer based on the perineural invasion. So you touched on the fact that the cribriform can occur around nerves. That's pretty often. Would you call that grade 4 if it's cribriform around a nerve, or would you hope that you could have something somewhere else that you can call grade 4?
I am very reluctant to call grade 4 in that situation, although I do not have very strong evidence for that. I find it, I have a very strong impression that from prostatectomy specimens in any case, that when you have an overall grade 3 prostate cancer, and then you see the carcinoma going around these nerves, that you, in this perineural location, they suddenly start getting a cribriform appearance. And then I think, hey, it's maybe induced by the basement membrane substances around the nerve or whatever, which triggers this kind of cribriform appearance. So I would be very reluctant unless it is very large. But when it is very large, you generally have already other patterns in the remainder of your prostate biopsy. So the answer is basically no, I would not include it in my Gleason grading.
Right, we've got a few questions. First question, size is not a criterion for calling cribriform pattern. Is there, however, a prognostic difference between small and large cribriform pattern? Does large cribriform behave even worse? So,
yes, that is an excellent question, and I think that has been addressed by one publication by the group of Dr. van Leenders. I think the first author is Esther Hollemans. They studied large and small cribriform pattern, and I think it was based on the size cut off between small and large was, I think, 2 times the size of a benign gland, which is always a little bit a tricky argument, I would say. But anyway, they used that consistently, and they demonstrated in these prostatectomy specimens that particularly of only the large cribriform pattern was associated with poor prognosis, and not when there was only small, if there was only small cribriform pattern. But that is one part of the discussion. Of one part of the answer. The other part of the answer is, when you read that paper careful, you notice that when there is large cribriform pattern, there's always small cribriform pattern also present in the prostatectomy. So now we have to think, what about prostate biopsies? And when you have a prostate biopsy, we know from several studies, I think there are at least 3 papers, showing that cribriform pattern, the sensitivity to detect cribriform pattern with the cribriform pattern in the prostatectomy as the final outcome, the sensitivity by a biopsy is only 50%. That means in biopsies you miss in about 50% your cribriform pattern due to sampling bias. So and now my argument would be that in prostate biopsies you may miss the large cribriform pattern due to the sampling bias, but then your small cribriform pattern could serve as a proxy for the large cribriform. So I would still consider small cribriform pattern as important to diagnose in your prostate biopsies for that reason. It's a bit a complicated pattern. So the answer is essentially, when it is large cribriform and you have a prostatectomy, yes, that is according to this one publication, it would be nice to have validated this, but according to this one publication, it is definitely more prognostic than the small cribriform. However, in a prostate biopsy, the situation is much more complicated due to sampling bias.
Okay, here's another question for you. Can immuno help in delineating cribriforming?
Ooh. I have to think about it. I'm not, you know, I'm a little bit an older generation pathologist, and I always have to wait for the immuno result to come. So I'm not the most enthusiastic immunostainer. I have no idea. I don't think the only reason why you could do that is maybe to highlight your intervening stromal or capillaries to distinguish from that complex fused or whatever you want to call this situation. Then it might help you to distinguish between the two. But personally, I have never used it. For the rest, there are no specific markers, as far as I'm aware, for cribriform pattern versus the other Gleason grade 4 patterns. If that were the case, it would be very happy. Probably they have much more often P10 loss, but again, P10 loss by itself would not be a very sensitive marker and would not be very applicable on an individual case-based base, I would think.
The next question is slightly crossing over, which is, what is your opinion regarding grading of intraductal cribriform carcinoma in biopsies? That old chestnut.
Well, again, I'm a very practical person, and I think we know intraductal has a poor prognosis. We know cribriform, particularly large cribriform, has a poor prognosis. And several publications have shown, a few publications have shown, not several, a few publications have shown that the impact, whether you grade it or you don't grade it, the impact in most cases is very limited. I think the situation is only important when you have a comedonecrosis, and there, oh my God, and there the problem starts again, because in the past, when you saw comedonecrosis, you would immediately call it Gleason grade 5. So all the old series before, say, the immunostaining, and actually before 2014, were based just on the morphology, seeing comedonecrosis. However, there is 1 or 2 publications showing that I think the overwhelming majority of comedonecrosis, you can see some basal cells around the rim. So then you have to call it intraductal carcinoma with comedonecrosis, and you would not include it in your Gleason score. So I always mention comedonecrosis in my reporting, no matter what. And yeah, from a practical point of view, I would agree to include the grade of the intraductal carcinoma in your biopsies. But of course, I have to say that because you put me in a very difficult position here. As the president of the ISUP, I have to support every recommendation made by the ISUP. I hope you have an understanding for my position.
I do. I'll ask you a quick question, moving swiftly on. So this is something you touched on. So expansile dense cribriform pattern with pseudo-rosetting. Is this pattern 4 or pattern 5? And how would you call it on a biopsy when only partially sampled?
Yeah. Yeah.
So I think this is quite tricky because we always debate on, is that a lumina or is that not a lumina? Yeah. If it's a lumina, it's pattern 4. If it's no lumina, it's pattern 5. Yeah. And I think there's probably a lot of variation amongst pathologists as to what they define as a lumina in these solid sheets.
And the problem is, so because in these pseudo-rosetting, you still see this glandular outlining because these nuclei are arranged in a glandular way. And if you are a very purist, then you would call it 4 because there is still a tendency of glandular differentiation, and that is 4. So to my big surprise, actually, in 2014 in San Antonio, there was a vote on this pattern. It suddenly came up. It was not really prepared. And then there was an overwhelming majority to call this pseudo-rosetting pattern, and they showed a few pictures, and to call this pseudo-rosetting pattern included in the Gleason grade 5. So the image I showed you, I actually deliberately put into it because I had thought that our 12 panelists would all call it a Gleason grade 5, but they didn't. And yeah, if you scrutinize that picture very carefully, you can see a few lumina, that means open lumina somewhere in that picture. So I don't know. Personally, I think it's not a really very important issue because we all know this is a bad pattern. It's really bad. So whatever you want to call it, it's a poor, it has a very poor prognosis. So I cannot really give a good answer to this.
Right, and moving on, in metastatic lymph nodes, should one comment on the presence of cribriform pattern? I mean, it's very common in lymph nodes, isn't it? When it metastasizes, it goes cribriform.
Yeah.
But is it important or?
No. Actually, Michelle Downs and me, we published a paper, I think last year, I'm not sure, in histopathology, where we analyzed actually the patterns found in lymph nodes. And we were thinking that when you have cribriform pattern in the metastatic lymph nodes, that would make the prognosis worse because we had some outcome data on that. It didn't. The only pattern which was predicting poor prognosis was actually the solid pattern in the lymph nodes, but not the cribriform. On the other hand, I agree, very often, but not always, you see cribriform pattern in the lymph nodes mets, but it did not have any prognostic impact in our hands. No, the Gleason scoring of the, if you want to do the attempt and do the Gleason scoring on the lymph node met, we and others have shown that indeed the Gleason score on the lymph node met has a prognostic impact. But the cribriform, no, it doesn't.
Here's another question. How would you diagnose large cribriform pattern at the edge of a biopsy when we only see part of the cribriform pattern? They really are splitting it down the line now, trying to.
This is an impossible question. I cannot answer that. The only point I want to make is that, particularly when you have large cribriform, is my impression, as a personal opinion again, you may have even also the situation that you see fragments of cribriform, loose fragments in your biopsy, so it dissociates earlier. And again, I do not make any attempt to call small or large cribriform in prostate biopsies. I call everything cribriform. I just call cribriform, and I think it gets too complicated and too granular also for clinicians to make use of it. And again, for the same, actually the reason why you asked this question, sometimes it's impossible to answer.
This is a question we often get asked. Do you recommend performing basal cell markers to differentiate from intraductal? I think I can feel the no coming on here.
Well, it depends a bit. If I have the suspicion it's only intraductal, so it's all the biopsy, you have that situation not very often, fortunately, rarely. But if I think there is only intraductal, yeah, then I would do definitely a basal cell staining. But if it is a mixture of intraductal and invasive carcinoma, I don't try. And sometimes it's because, yeah, you want to give the percentage of, you have to give the extensive percentage of involvement of the core by invasive carcinoma. But I just include actually the intraductal. I consider the intraductal as a part of the carcinoma component, which it actually is. It is carcinoma infiltrating into the ducts actually. It's not a precursor lesion really.
This is a good question. So you were discussing about the size and that there was no real criteria. But this question, is there a minimal number of luminal openings in cribriform pattern? How many holes do you need?
Yeah, well, 3 is obviously too little. I love to see 6. 6 is a bit for me a kind of, well, that's a good number, but maybe it's too high. I don't know.
I can see that being in a paper and proving someone else arguing that out. Right, the next one's going to take me a while to read.
But 6 is not in the definition. I could not get consensus among the panelists to say 6. I hope they would say that, but I couldn't get consensus there.
Yeah, I can imagine. Tumor growth patterns have mainly been studied in radical prostatectomy specimens. There seems to be less heterogeneity of growth patterns in lymph node specimens. For instance, he's never seen glomeruloid lymph nodes in the METs. What is your experience with these growth patterns in lymph node metastases?
Well, I would refer again to this paper by Dr. Downs in histopathology. Well, we were surprised. Well, glomeruloid, I don't think I have ever seen in a lymph node met. No, I don't think so. However, we see typical Gleason grade 3 glands in lymph nodes. You could, of course, the grading is a bit more difficult and tricky in a lymph node because the stroma is not there, but you can see separate grade 3 glands there, fused glands, single cells, the whole repertoire is there. I would say. So yeah, but glomeruloid, no, I don't think I've ever seen it. That's a good point. To be honest, I didn't realize that until you asked this question.
We'll have to start looking extra hard. So here's another question. Is there a molecular background for cribriform pattern?
That's an excellent question. Well, maybe excellent because we did quite a bit of work on that, we and others. And yes, there is. So the cribriform pattern, although often studied together with intraductal, is associated with much more genetic alterations. If you look at the genetic instability, so you look into the whole genome, you see overall much more genetic alterations like deletions and point mutations even. And although point mutations are rare, and so that is one thing. And there is one, for cribriform and intraductal, there was only one marker which is associated also, and that is a long non-coding RNA, which is called SLAP1. And some previous studies showed that this long non-coding RNA, which is quite specific for prostate cancer, it's in no other cancer or no other tissue, and you can see it, except I think in some brain tumors, in glioblastoma. But the SLAP1 was strongly associated with intraductal and cribriform carcinoma. But I think the main thing is that it is associated with genetic alterations like MYC amplification, P10 deletions, and all these other genetic things. So yes, which actually gives it a bit of more molecular pinpoint molecular basis for this to separate this cribriform pattern from the other patterns.
Now the next question is somewhat controversial, I think. I think that diagnosing, it's not me. I think that diagnosing a cribriform pattern on a biopsy when there are only small cribriform glands is not so crucial, since it is still a pattern Gleason 4, and prostatectomy will probably follow. It is probably more important to diagnose it definitely on prostatectomy. What do you think of that notion?
Well, actually, it's an interesting question. I think the point is that we all know that Gleason score 6 prostate in biopsy Gleason score 6 cancers, those patients are eligible for active surveillance, but clinicians increasingly include also Gleason 7-3+4 in biopsies if other clinical and pathological criteria are not too bad. They would include them as well into the possibility to have active surveillance. And in our center and in many centers, I think the idea is that when you see cribriform pattern in your biopsy, even so in a 7-3+4 biopsy, they should not be eligible for active surveillance. And I really strongly support that. I would think so, particularly because it can be associated with it has been shown that presence of cribriform pattern in a Gleason 7-3+4 is associated with extra prostatic extension and all other kind of unfavorable characteristics.
So I would agree with that. I think it's more important in the biopsy. By the time you've taken the prostate out, basically they've had their treatment, and the recurrence rate is so low that probably not very important in the
prostate is gone.
Yeah, exactly. After radical prostatectomy, the recurrence rate is pretty low, isn't it? So you want them to have their prostate out. So maybe not. Now this one is going to take me a while to read. A relatively recent publication done by Dr. Fine demonstrated that complex solid glands showing comedonecrosis quite often show presence of basal cells using staining. And this is what you said earlier. This is concordant with my personal experience, as in the lab I work, we routinely perform 34 beta staining in prostate needle biopsies. How do you deal with this in biopsies and RPs, as may have significant impact on the final Gleason score? I think you discussed this. Do we call it pattern 5? We do the basal markers, suddenly it's pattern 4 because it's intraductal cancer, and we shouldn't be grading it and what have you.
I include it in any case in the Gleason score, but I make a comment also that there is comedonecrosis, comedocarcinoma. Yeah.
But you'd grade IDC with comedonecrosis as pattern 5.
Yeah, sure. Yeah, I do.
I think that's probably what we always used to do, isn't it? And I don't
we always used to do that. Yeah.
Doing basal markers is really going to help it. And as you often say, it probably doesn't make a lot of difference to the patient it's
No.
sort of management for the next step.
Yeah.
But it may.
They would certainly not go in active surveillance. No.
No, hopefully not.
Probably not even prostatectomy. No.
We're doing how are we doing for time? Yeah, we're coming to the end. So would you consider different nodules that are totally made up of cribriform cancer from nodules that show cribriform and non-cribriform poorly formed gland areas? Would you consider differently nodules that are totally made up of cribriform cancer from nodules that show cribriform and non-cribriform poorly formed glands area? I'm not sure. I don't quite understand the question.
You mean in a prostatectomy or maybe, but
yeah, I think I don't quite understand the question. So that is, you've done very well, Theo. We've come to the end of all the questions.
Thank you so much.
I think actually you've uncovered lots more questions. Some of that presentation. It's glad to know that some of the experts don't agree on the stuff which we we have problems with. So thank you very much, Theo, and you can now relax, and it's glad to know that your fire alarm is working in your building. That's the important thing.
I did not foresee that.
We wish everyone a happy Christmas, and the next ISUP Presents will be at the end of January, which will be on renal cancer patterns and immunohistochemistry. So until then, these lectures will be available. Unfortunately, this YouTube hasn't worked on this one, but I'm hoping that I'll post up the recording in the next 48 hours. So I think that's it, Theo. And
thank you very much.
And good night or good afternoon.
Thank you all. Yeah, thank you also for listening. Yeah, thank you. Yeah.